Well, good afternoon, everybody. Welcome to the Houston Health Department Monkeypox Forum for Healthcare Providers. Our goal today is to facilitate a productive exchange of information. We want to hear your voices, which is why we have reserved a good portion of this forum for Q&A at the end. So please hold any questions until then. This is intended to be a two-way conversation. So we have set these forums up as a meeting rather than a presentation. So please be mindful of that and place yourself on mute whenever you're not speaking. We have a very full agenda today, so let's get this forum started. We'd like to start it off with some words from our local health authority, Dr. David Purse.
Thank you, Roger, and hello, everyone. Just a couple of little things. First of all, the monkeypox situation, I'm just looking at the stats right now. So across the city of Houston and Harris County combined, just under 700 cases at 693 by the data I'm looking at, 536 within the city of Houston. And that continues to go up. Now there's it looks like maybe the rate of increase is slowing down. So that's good news, but you don't know if you've peaked or leveled off until you can look back and see it. So I'm not holding my breath, but maybe some good news. But I just do want to take a moment. Look, this is really complicated. This whole situation has been really complicated, and things are constantly changing. And in addition, we're doing this sort of a little bit in the wake of COVID. So we have a population now that is, on one hand, paying more attention to public health and some of the messaging we're getting out. We also have a public that's pretty divided on things like vaccine and so on and so forth. And in addition, we are trying to target a population where we feel are at most risk for contracting and spreading, simultaneously trying to protect an overlapping but not exactly the same group of people who are at most risk should they become infected and would be at greatest risk for having serious consequences. So none of this is easy, but I got to say I'm really proud of the work that we've been doing. We will always get criticized by somebody for something. And there's usually some good information in those criticisms that we can learn from. So I accept it and I actually welcome it. And we'll do better next time. But anyways, I want to thank everyone for joining. And we've got some folks here that'll be able to hopefully answer some questions. And with that, Roger, I'm going to turn it back over to you.
Well, thank you, Dr. Purse. It's always great to have you on. So next up, we have one of our permanent agenda items. We have Kirsten Short, our Epidemiology Bureau Chief, and Kelsey Caton, a member of the data sciences team, and they'll present a data snapshot of the monkeypox response here in Houston.
Hey, Roger, thank you so much. Let me go ahead and share my screen because I do have slides as we go ahead and talk about this a little bit. We don't want to spend too much time on this, but we do want to put everything in perspective. So as before, we're going to start globally and work our way down. So we are up to about 56,000 cases globally. 99% or more of those cases are in locations which are not considered endemic to monkeypox transmission. Those would be those on this map with the yellow or orange dots. The US is the country with the largest number of cases, followed by Spain, Brazil, Germany, and France. Globally, we've seen less than 20 deaths. They also are able to split those deaths up. A little over half of those have occurred in locations that historically report monkeypox, and slightly less than half of the deaths in locations that do not traditionally report monkeypox. The US does not have any deaths reported. We have had some conversations that have been reported through the media of some deaths that are under investigation. But right now, those investigations are still ongoing, one here in Harris County, one over in California, to see whether those would be classified as deaths associated with monkeypox. So as we drop down into the United States, we have about 21,000 cases in the United States. Texas has the state with the fourth highest case count, preceded by California, New York, and Florida. So nothing terribly shocking in there. One of the things that we're able to see from the United States is the cumulative positivity rate. So this is all of the tests that are reported from public health labs as well as commercial labs across the United States. And so this cumulative positivity rate from the beginning of the epidemic until now has dropped down slightly to about nearly 30% or just under 30%. And what you can really see is that as of about mid-August, The rate has more or less stabilized with maybe a slight decrease going from about 25% to 24% to 23% to 22% for the week that ended on September 3rd. And you can see this most recent week, they don't have complete data reported in yet. So that goes a little bit to some of Dr. Purse's comments. We may or may not kind of be stabilizing at the moment. Again, the population continues to, the population that tests positive continues to be the population that is predominantly male. Most are in sort of the 31 to 35 age group, or just more broadly in that sort of young to early middle-aged adult. And then over the course of the outbreak, we've seen an increasing proportion of Black and Hispanic persons test positive when compared to some of those early testing weeks. One thing I did want to mention this time is that CDC in the beginning of September did release their second technical report on the monkeypox outbreak, and I'll drop the link for that in the chat if you guys haven't seen that before. And so this is a little bit different from their other slides. It really is intended for a technical audience. So if you like that sort of thing, I encourage you to go and dig a little bit deeper. Some of the things they've got in here is, remember, we talked about case counts. And so this figure from that report is trying to put those case counts a little bit into population perspective. So looking at the number of reported cases per an estimated population, and that population denominator, they're looking at MSM, men who have sex with men who are living with HIV or AIDS, as well as MSM, men who have sex with men who are eligible or indicated for PrEP or preventive HIV therapy treatment. And so those two populations together. And I can also drop a link in the chat about where they got that denominator data from if you're curious. But so you can see here that shifts a little bit of where you see sort of the intensity of this outbreak within state level populations. And then the last thing I wanted to do before I turn it over to Kelsey is just sort of talk very broadly about Texas. As Dr. Purse mentioned, we have about 1,800, a little over 1,800 cases in Texas. Again, most of them are falling in that 18 to 49-year-old age. They are predominantly male, just like the global. They are clustered or in the metro area, up with Region 2-3, which is the Dallas-Tarrant County area, and 6-5 South, which is our area, Houston, Galveston. And overall, Houston specifically is going to account for a little over a quarter of all the cases in Texas. So let me go ahead and mute myself, and I will turn it over to Kelsey.
Kelsey, if you're talking, we can't hear you.
Hi, can you hear me now?
Yes, ma'am.
Okay, thanks. So moving on to the city of Houston, this is data as of September 2nd. So these numbers are a little more dated than what Dr. Purse mentioned, but the figure on the left here shows the current trends in testing and positivity for the Houston area. And we are using the 105 city of Houston area zip codes to get this data. We're still seeing, just FYI, that many reporting labs have a 3-day plus lag between the actual specimen date and the date we receive the results in our surveillance system. So this data is as of September 2nd, and the black dotted line is on August 30th, indicating this lag time frame. The centered 7-day positivity rate for August 29th is at 41.3%. And it's been kind of hovering in the low 40s for a few weeks now. Next slide. So here are some of the demographics for our the case count as of September 2nd, which was 481 cases. We do see similar trends in Houston that we see, again, from CDC and DISH's numbers. Most cases are between the ages of 20 and 39, and almost all our cases are males. For race, the majority of cases reported being white, followed by Black or African American. And for ethnicity, the majority of our cases were reported as non-Hispanic. But to note, we do have quite a big portion of ethnicity values that are coming in as unknown. And we do, for as far as like contact tracing numbers, we're currently generating less than one contact per case here. Next slide. So here is a map of the cumulative monkeypox case counts by zip code. And we are suppressing zip codes with less than 5 case counts in this map. Currently, a majority of the cases have indicated that they reside in kind of the central to mid or southwest region of Houston, with 77006, 77007, and 77063 having the highest cumulative counts currently. Next slide. And then as far as like monkeypox and HIV diagnosis, 37.4% of our current monkeypox case counts are also confirmed to have be positive for HIV. And the second graph on the right here presents the HIV viral suppression among the monkeypox cases with HIV. So among these individuals, 20.6% were virally unsuppressed at their most recent HIV viral test and may be harder to reach for vaccination because they may not see their provider regularly. And I think that's it.
Well, thank you very much for that information. The stats really do always tell a story. Moving right along, we have our next speakers, which is our laboratory manager, clinical laboratory manager, Dr. Melan Bilby, and Ricardo Quijano, who is the supervisor of our molecular diagnostics and laboratory response network operations. They'll be speaking a little about laboratory testing.
Thank you, Roger. Let me share the screen. Can you see it?
Yeah, we got you.
Thank you. So for monkeypox specimen collection, there are some online resources available. There is a YouTube video on how to collect monkeypox specimen. Our lab specimen collection guidelines and the test request form are available on our Houston Health Department website. CDC recently updated monkeypox specimen collection guidance to include tips for adequate collection of a lesion for monkeypox testing to avoid or reduce inconclusive results. We have seen about 15 to 20% of specimens with inconclusive results. I will drop all these links in the chat. The details are in the guidance. I would like to mention some key points. Do not clean the lesion with ethanol or any other disinfectant before swabbing. Collect 2 swabs from each lesion, 2 lesions per patient, preferably from different locations and in different appearance. Apply firm pressure. This might cause discomfort or slight pain, but it is necessary to obtain adequate DNA. Swipe the swab back and forth on the lesion surface at least 2 to 3 times, and then rotate and repeat on the other side of the swab at least 2 to 3 times. The goal is to obtain sufficient human DNA to avoid an inconclusive result. Try to avoid using VTM tubes. If you can, specimen might get diluted. Most of our inconclusive results are from specimens submitted in VTM tubes. The testing method we use in our lab is a CDC-LI non-variola orthopox real-time PCR. This test is not a monkeypox virus generic or West African crate specific real-time PCR test. We have received a lot of questions on this. Non-variola orthopox includes monkeypox, cowpox, vaccinia, etc. Currently, the known orthopox virus circulating in the United States is West African monkeypox. So if it is positive for orthopox, it is safe to assume it is West African monkeypox until other strains of orthopox are found to be co-circulating in the United States. You may ask, how do we know there are no other strains of orthopox co-circulating in the United States? CDC has a surveillance program in monitoring this by sequencing positive specimens from all over the country. These wide testing results are sufficient to drive treatment decisions and public health actions. The test method we use is not affected by the tumor necrosis factor receptor gene deletion recently discovered in California. At this point, it is believed that this gene deletion is rare. Before I get into the result interpretation, I would like to briefly talk about what a cycle threshold CT value is about. This picture shows the amplification plot after the PCR run is complete. The red line is a threshold we set when we analyze the data. Normally, the threshold is set in the middle of the exponential phase of the amplification plot. I'm sorry. Let me go back. Sorry about that. So the corresponding amplification cycle where the threshold cross over the specimen amplification curve is the CT value for this specimen. For example, this one is about 22.3, and this one is about 37.5. The lower the virus concentration in the specimen, the higher the CT value, because it takes more amplification cycle for the amplification curve to show up. For example, this specimen with CT value of 37.5 has lower virus concentration than this specimen with CT value 22.3. Now we know what the CT value is about. Let's look at the possible results. The test targets at two markers, the virus, non-orthopox virus marker VAC1 and the RP marker for monitoring the quality of specimen. RP should always be positive, which means the CT value is less than 40 if there is a sufficient human DNA present in a specimen. When virus marker VAC1 CT value is less than 37, we call a specimen positive regardless of the RP CT value. When virus marker VAC1 CT value is between 37 and 40, we call a specimen equivocal regardless of RP CT value. The difference between a negative and an inconclusive result is in the RP CT value because the virus marker VAC1 is negative with a CT value of greater or equal to 40 in both cases. But when the RP value, CT value is less than 40, which means it's a positive, then we call the specimen negative. It is confusing, right? But when the RP CT value is greater than or equal to 40, it means there's not sufficient human DNA present in the specimen, often due to improper specimen collection. So the negative virus marker may not be a true negative. It is called inconclusive, which require resubmission, collection and resubmission of specimen for testing. False positive and false negative results are not common, but can happen. There are several contributing factors. Testing methods normally do not have 100% sensitivity and 100% specificity, which means possibility of false positive and false negative. Very early or late stage of disease, medical treatment, co-infection, specimen not collected, stored, or transported correctly, misstep during the testing process can all contribute to false positive or false negative results. You might ask, how can I know a result is a false positive or false negative? That's why it is very important that for patient management purpose, test results should always be used in conjunction with clinical observations, patient history, epidemiological information, other differential test result, and when in doubt, collecting and submitting additional specimen for testing. For example, you have a patient who have lesions just like monkeypox, who happens to have known exposure, but the test result come back negative. You can contact a lab to verify result, but most likely you will need to collect additional specimen for testing. In the meantime, you might want to look at differential tests for other disease. Sometimes every indicator might point to monkeypox, but it is not, and vice versa. We are here to help you resolve those questionable cases. So contact our laboratory if you have any questions. That's all I have. Ricardo, do you have anything to add?
Yes, Dr. Bilby. I did want to point out a few of the errors that we see during collection that I would like to cover to hopefully make the collection process more successful for everyone. I know that a lot of labs don't have all the resources to do the collection, and so they're trying to use COVID kits sometimes to do the collection of monkeypox samples. And I want to point out that some of those COVID kits have the swabs that are meant for a nasopharyngeal collection, which means that the shaft is a little bit bendier because it's meant to go up your nostrils. I do want to point out that we do see that these usually end up being inconclusive. With that more flexible swab, it's harder to do that vigorous collection that's required. So we would like to ask that if you have those types of swabs, if you can try to get a different type, one that's more rigid to allow you to do that vigorous collection, it'll allow us to get better results for you. Another thing is, I know some people, again, because they don't have all the required things to do the collection, they're putting the swabs in urine collection tubes. We've noticed that when y'all do this, y'all tend to cut the swabs. We would like to ask you that when you do cut the swabs, don't cut them too short so that they sort of just move around that urine collection tube. Make the shaft just slightly lower than the cap so that when you put the cap in, it'll put pressure on the swab and keep it from moving all around. When the swab moves all around in that larger tube, we may lose some of the virus that you collected on the end of the swab. And again, it can lead to an inconclusive result. We do want to encourage y'all to continue to collect duplicates. And when you do collect them, to please make sure you label all of your primary tubes accordingly with the correct lesions. We have seen that some people are confused and they put the duplicate swabs together in one tube. That shouldn't be done as well. Make sure that you have an individual swab in an individual tube. And then as always, just remember that this is a UN 3373 category B sample. So it does require some form of triple containment. So we would like to remind you to remember your training when it comes to shipping these to the lab for everyone's safety. And that's all I have. Thank you.
Back to you, Roger.
Hey, Yeah, thank you, Dr. Bilby. Thank you, Ricardo. I really appreciate those tips and the technical knowledge. It's good to really thoroughly understand the tools we have in our toolkit, right? So next we have Gilmont Pierre and Guadalupe Valdivinos. They'll be providing an overview of just some of the monkeypox resources and educational materials that are available to you.
Thank you, Roger. Good afternoon, everyone. My name is Gilmont Pierre Fuller. I am the division manager here for the Office of Chronic Disease, Health Education, and Wellness. This afternoon, I'll just briefly discuss with you all some of the general health education efforts we have going on with the department that can be of a resource to you all as providers. And then, of course, later on, my colleague Guadalupe will then share some of those special population efforts as far as education and outreach that's going on with the department right now. Let me go ahead and share my screen briefly, and then we'll go ahead and get started. Okay, we're just gonna go ahead and keep it going. Of course, with our motto is making the healthy choice the easy choice. So of course, we would like to make health education very accessible to individuals, either in person, self-paced, virtually. So we do have a lot of different avenues where individuals can access monkeypox education as well as in different languages. Traditionally, we are a chronic disease office, so we work a lot closely with more general population where we discuss everything from nutrition, healthy eating, diabetes, active living, tobacco. But more so recently with COVID, we've been able to get more into the space of infectious disease education with COVID and now with monkeypox as well. Our goal largely is to address and really influence individuals' awareness, their knowledge, skills, their attitude, and hopefully their behaviors around making healthy decision and health promoting decision to ensure that they have an optimal quality of life, which are free of diseases. I will jump into a little bit more on the broader level, and then we'll drill down into the level that I work on, and then Guadalupe at the level that she works on. So the Houston Health Department broadly, we do have a public affairs and the public information division where they do a lot of different communication tools. So they do release, they do have news releases where they release routinely, and they work a lot with our media agencies and provide information and resources that way. We do also host our main Houston Health Department website. It has been retooled, so it is a lot cleaner now. So you are able to access the monkeypox information very directly. So at the very top of the tab, the information will be there. And then as well as links to different resources. So that's just another level of access to resources and education on monkeypox for both the community as well as for providers. Additionally, the Public Affairs and Information Division also has various amounts of social media platforms. This screenshot is of our current Facebook page. We have about 42,000 followers, but we also have a Twitter page as well as an Instagram page where we are able to share shorter blurbs of information on monkeypox as well as other diseases as well. A lot of the comments have been, well, does the health department have a TikTok? No, we don't, but the mayor's office do, and we do provide them information to share on that platform as well. So we do have the social media platforms covered as far as resources for information and education. Lastly, I do want to share that the Houston Health Department does have the Houston Health Scope, which is the monthly newsletter that we share, and it is a newsletter that is accessible to partners as well as community members, where we share information about new resources, new classes, new services, as well as updates on diseases and vaccination status as well. And everyone have that access to subscribe to the newsletter. I very much encourage it. It is one of the premier routine places where you can get information sent to you if you're not routinely going to the website or going on social media to access information. I do want to drill down to my team, to our level. I am the manager of our community-based health education team. We are although you would think health education is just educators, but we do have a very diverse team, including graphic designers, webmasters, analysts, just different folks who make up health education and health promotion in our area. Largely, our services and our processes include developing the material, adapting it to plain language, adapting it to other languages, either Spanish, Vietnamese, and things of that nature. So we spend a lot of time adapting technical or medical information to plain language so individuals can understand it. We do provide materials in just either mailing it or delivering it in person to partner locations, whether they are apartment complexes, churches, community centers, as well as our medical partners as well, if they are in need of printable resources as well. We, of course, partner with tabling events, different cultural events out in the community. We do a lot of in-person presentations by request, but we do have the classes and the modules available self-paced, so individuals can just log on and take those courses at their own pace. And of course, we do provide technical assistance to different organizations who are interested in also using the same materials or the same language that we're using to do education. We are able to cross-train partners to do education on with their population as well. So currently, some of the options we have in our health education portfolio with regards to monkeypox, we have our general understanding monkeypox presentation is very short. I want to say it's about 30 minutes, including pre and post tests. We do have a preventing monkeypox in the healthcare environment, and this is more so targeted to frontline healthcare workers, so the allied staff, the janitorial staff, the front desk individual. So that is who this presentation is more so targeted or is focused on. More recently, we're in the process of developing our post-vax tool or education for monkeypox because it's a little bit different in COVID. And then lastly, we're working on developing our wellness beyond monkeypox, just to reiterate some of our wellness and healthy eating, active living, and making more conscious and safe decisions for health promotion beyond recovery from monkeypox. Of course, as I mentioned, we do offer technical assistance to our partners. We do have some grassroots partners who are also doing outreach and education, so we do cross-train them and explain some of this new information to them. And lastly, we do have the provider training, which is the infection and prevention and control training, Project First Line. This is the CDC provided curriculum and is vetted by them. It is one of the grants that we're also working on, and the goal for that initiative is to train frontline workers on basic infection prevention and control protocol. So those are some of the major resources that are available to the community as well as to providers. This is just a screenshot of our Project First Line initiative. Essentially, an organization can just take an needs assessment and then just go ahead and register for the course online. And this is all accessible on our Houston Health Department website. As soon as you click the monkeypox tab at the very top, all of these resources are organized for you to be able to access them. Lastly, I did want to share some quick I did want to share some quick infographics about some of our modules. They are both available in English and Spanish. These are our live virtual presentations, as well as if an individual or an organization really would like to request a speaker to come to their organization, we do have that option as well through our Speakers Bureau. And all of these infographics will be provided to you all at the end or at the conclusion of this call. So like I mentioned, we do have a couple different delivery options. We have our general health education services, which are presentations. They are in person, they are virtual, and they can be self-paced. We do accept requests through our Speakers Bureau platform. We do partner and collaborate for outreach events, whether it's even a PTA night with schools and things of that nature. And we provide technical assistance for community health workers and different grassroots groups who are interested in working with us to amplify the message of monkeypox prevention. All of these are available online through the Houston Health Department website. All of these links will then already embedded online, so you don't have to take the time to copy them. So they're all accessible to you on the Houston Health Department website. And of course, if you have any questions or if you are looking to collaborate on health education, you can reach out to me, gilmac.pierre@houstontx.gov, or just for general health education services requests, just email healtheducation@houstontx.gov. And that concludes my piece for today. I turn the floor over to Guadalupe.
Hello, good afternoon. Can everyone hear me? Okay, thank you. So I am Guadalupe Valdovinos. I am currently serving as one of the leads for the Special Populations Education and Outreach, as well as the liaison for the LGBTQ plus community organizations. And I work with the Bureau of HIV, STD, and viral hepatitis prevention. And so what we do is we work in partnership with the community to assess, to plan, and to implement effective public health strategies to reduce the spread of HIV, viral hepatitis, and other sexually transmitted diseases in Houston. As it relates to monkeypox, we are working with special populations. So those communities that are being disproportionately affected by monkeypox. And so I will share with you a little bit about what we have been working on currently and lately. As of this last couple of weeks, we have increased some of the partnership work with our community organizations. So for a while, we have been working with our HIV treatment and excuse me, and care clinical partners to provide monkeypox vaccine to their clients. And these are organizations that that provide services to the LGBTQ plus community and people who are living with HIV. And so in efforts to expand our monkeypox education and vaccine access, we have partnered with these community organizations that don't necessarily provide that clinical service, but like I said, they are serving the LGBTQ plus community and people living with HIV. And so we started reaching out to partners who were willing and opened their doors to allow us to come on site and provide a vaccine access to the community members that they are currently serving, and those where individuals in the community feel safe and comfortable going to receive services. And so they're responsible for recruiting. So far right now we've partnered with the Normal Anomaly, with AIDS Foundation Houston, with FLAWS, and the Montrose Center. These organizations, they have the space, they have the clients that meet the criteria for vaccine. And so we are taking the vaccine, the staff, the support, and the resources out to them. The clinic schedule for these pop-up vaccination clinics are during traditional and non-traditional hours because we want to accommodate the community members' schedules and eliminate barriers. We are also working with bars, clubs that are epi-linked to active cases reported. Some have reached out to us, others we have identified. We have two approaches with these venues. We have met with the owners of some of these bars, and they are allowing us to use their space to provide these pop-up vaccination clinics during day hours for the individuals that they recruit. Our current approach right now with these bars are the mobile vaccine clinics during club hours, which are non-traditional. So that allows us to hit several of the area bars all at the same time. And so our plan is to have 2 mobile units at the corners of the bars, the neighborhood where they are. And each agency will use their own tools to promote and to recruit, such as their social media, having flyers throughout their facilities. And we we're able to provide the literature, the content for their flyers to promote the vaccine events, as well as the Houston Health Department flyers and educational material. Also, we have and continue to provide these organizations actual printed material so that they can provide to the community during their outreach efforts.
Guadalupe, you're
We,
on mute
we
right
lost
now.
your mute. Yeah, sorry about that. We lost your volume.
Okay. Can you guys hear me now?
Yes, ma'am, we got you now.
Yes. Okay, so I'm not sure where I left. Did you guys, I was talking about the educational messaging that we have running on Google Ads, as well as dating apps such as Grindr, Scruff, and Jacked. So that's where we are with special populations education and outreach. If you have any additional questions or would like to discuss possibly an assessment of your organization, your space, for us to provide a mobile vaccination clinic, I will put my contact information in the chat. Thank you.
Dave, thank you so much for all that great information. Next, we're going to move on to our last fixed agenda item, which is a monkeypox case presented by Dr. Gina White, the Deputy Health Authority here at the Houston Health Department.
All right, Roger, thank you so much. So let me just say the case today is going to be presented by Kendrick Clack. Kendrick is a board-certified family nurse practitioner who practices routine primary care. His clinical experience includes the management of patients living with HIV, hepatitis, and gender-affirming care. He has certifications from the American Academy of Nurse Practitioners and the American Academy of HIV Medicine. He's received numerous recognitions. He's been Nurse of the Year. He's been 40 under 40 leaders in minority health. And some of his professional and civic engagements include the American Association of Nurse Practitioners, National Black Nurses Association, Association of Nurses in AIDS Care, Delta Phi Upsilon Fraternity Incorporated, and Gay, Lesbian, Bisexual, and Transgender Political Caucus. Kendrick is a veteran of the U.S. Navy, Nurses Corps, and he currently works at Crowfoot MD Clinic and Research Center. So with this, I'd like to introduce Kendrick to do a vignette of a case.
Good afternoon, and thank you, Dr. White. Get my screen up here. All right, so this is a gentleman. Can everyone hear me?
Yes, sir.
All right, so this is a gentleman who we saw early on within the onset of presentations back in a couple months ago. He's a 27-year-old white male. He presented to the clinic with complaint of lesion to the right side of his nose for a couple of days. He also had painful rectal lesions. At this time, he had a temperature max of 101.6. He had chills, malaise, headache, and some bilateral lymphadenopathy on the neck and groin. He reports having one male partner within the past 3 weeks, and who is also having swollen lymph nodes. His partner tested positive for pharyngeal gonorrhea, and he was treated for that 3 days prior. The patient is currently on prophylaxis for the treatment of the exposure as well. The patient denied any travel within the past 3 weeks or visiting his sexual venues. Objective data. So on the date of the visit, his temperature was 100.5 and he had a heart rate of 106, and his pain level was at a 5 out of 10 at that time. On the exam, he looked very ill appearing, no acute distress, and then the oral exam was fine, but he had the cervical lymphadenopathy still present, was tender. On the lesion on his nose looked kind of honey crusted lesion it measured about a centimeter at the time. He also had some bilateral inguinal lymphadenopathy. And then the rectal exam appreciated some lesions at 1 o'clock and between 7 and 9 o'clock. So testing at that time, because of the honey cluster presentation, I did a swab for bacterial swab. And of course, also did the orthopox swabs for the rectal and nasal lesion. Then also he had previous STI testing because he had been there 3 days prior due to the exposure. So at this time, we for the acute pain, I gave gabapentin 3 times a day, and we talked about sitz baths. For the fever, we talked about continuing ibuprofen and Tylenol he had been using. For the nose lesion, I called it at that point in time cellulitis, so I gave some effervescent ointment. And then we talked about isolation. One thing that's very important, I encourage him to be very careful not to rub his eyes because of the proximity of the lesion on his nose. And also informed him if he did have a increase in pain becoming in the eyes or the mouth, that he should go to the emergency care because that could be very compromising. So the next day, we got the confirmation of the swab that the orthopox was positive, and so we requested TPOX at this time because of the nose lesion and the rectal lesions have been very painful. On day 2, I got in contact with him. His pain wasn't improving, but his temperature had improved to around 99. So at that time, I prescribed 5% lidocaine ointment for rectal pain. About 3 days after, he had started the TPOX twice a day, and his lesion on his nose had increased to about 4 centimeters. The lesion at that time looked very similar to the lesion that the gentleman was who shared his case on the mouth lesions. So about day 10, this was day 7 of TPOX treatment. He was tolerating medication very well. He had no side effects, and he shared that he had improvement in pain, and the lesions had to begin to improve and had some crusting. He found better. He shared that he also found better pain relief with the topical analgesic being applied. His mental state was good. He described that he was connecting with friends and family via FaceTime. His rectal issues had resolved as well. Day 17, which is day 14 of TPOX treatment, he had no new lesions at the time. The lesion on his nose had a new layer of skin over it, and his mental health was still good, and he was getting back to his normal activities. So day 24, which is day 21 of TPOX treatment for follow-up of the protocol, he was back to his normal routine. And so in summary, some lessons learned. So the training, it was, we had just received the training here at our clinic in regard to monkeypox from one of the state medical physicians. And so at the point of the presentation, leaning back on that was very important to ensure that we activated proper PPE and collection of the sample to be processed. So it also kind of reduced some of the anxiety around handling the case. Containment. The location of the lesion was very sensitive, so it was imperative that I emphasize to the patient about the location and limit the contact to other areas to avoid auto-inoculation. Hand washing is very important, and also isolation from other folks. Teamwork. So the frequent check-ins that we are listed were all possible due to support staff from clerical staff, nursing, medical assistants, and the clinical pharmacists of the team. Pain management. So early on, the Neurontin was an intervention that I had heard from one physician that he was talking about something that he had experience with. But to know that this patient's experience was better with topical analgesics. And so I began to use that as a first line, and moving since forward, most patients have found good relief with the topical lidocaine ointment analgesic. So common things occur commonly. I like when Dr. Gale said that on the very first meeting that we had as providers, because again, this patient presented with some symptoms that could be associated with other common STIs. So we did do the testing for the full workup, and those came back negative at this time. But for cases down the road, I've had people also have positive rectal gonorrhea chlamydia at the same time as presenting with monkeypox. So comprehensive exam and PPEs are important. Test turnaround. So we were able to start the TPOX treatment within 3 days of clinical presentation due to the quick turnaround of the testing with the Houston Health Department. So we have used commercial labs as well, but we found that it takes about 3 days to get those back. So in time-sensitive cases, we've been sending samples to the Houston Health Department. And so last but not least, the mental health. 3 weeks isolation can be challenging. So found that the patient was connecting through FaceTime. Was very helpful for him to stay connected with community and get him through the period of isolation.
Thank you, Kendrick, for that case. And Roger, I know you want to kick it back and have time for the audience, but again, thank you for that clinical experience, because I know we're all seeing patients at different stages of this epidemic or outbreak. And so hearing best practices or what other practitioners are doing to support their patients. And I'm glad you also mentioned the mental health is a great opportunity for us to learn from one another. So thank you.
No problem. Thank you for the opportunity to share.
Well, yeah, thank you. Thank you very much. So that concludes the presentation portion of that. So the floor is now open for questions. You can either use the raise hand function or type a question in the chat and we'll try to get to it. We have only about 8 minutes left. That's my fault. I ran over a little bit, so I will be quiet and we'll answer some questions for you. In addition to our panelists, we have a wide variety of our other public health experts on the call to answer your questions. Okay, so first question from the chat. What is the turnaround time for a monkeypox test at HHD? Sure, I can answer that one. Our goal is 24 hours, but we are our stated is up to 72 hours. Just because if something happens on the weekend, or if there's a retest needed, something like that, it can extend that that period. But we are trying our best to turn things around in 24 hours. Okay, can MPX vaccine be given at the same time as other vaccines? Dr. White, do you want to take that one?
Oh, so current guidance right now is while monkeypox can be given in coordination with other vaccines, it's not with COVID. So for the COVID vaccine, they would like for you to wait 4 weeks. However, understanding if the community concern about the outbreak for monkeypox is such that it warrants it, then you can go ahead and give the monkeypox. But if they've had COVID, you would really try to wait the 4 weeks.
And correct, we're trying to, whenever possible, do the monkeypox along with hepatitis and meningococcal where warranted, correct?
Correct. The state did give some expansion that if you're seeing individuals and they qualify, then they want us to give the hepatitis A vaccine along with the meningococcal.
Okay. What is the youngest age that MPX vaccine can be given under the EUA?
So currently right now, what we've been doing is while you can go under the age of 18, there's some unique considerations for vaccinating an individual under the age of 18. So often what's happening in those cases is guidance from your health department to really give additional guidance on what would make that person eligible for vaccination. And in certain circumstances, based on that criteria, then we would go ahead and have them vaccinated. It can go down, certainly into younger years, but again, it depends on the scenario of why the person would be at risk. And so we really want to do those tailored with our epidemiologists just to sort of what we call do the risk stratification of why a person would need to be vaccinated under the age of 18. Let me go back too, because there's some considerations under the age of 18 with regards to the consent. And so that's where it's been a little bit of a challenge. Many of you know that we certainly think about our adolescents and wanting them to push in. We do have adolescents who are on PrEP. We have adolescents with STIs, and that is an eligible criteria. The challenge right now is several calls that we've had with CDC, and they understand with the current language, because this is not considered an STD, the privacy ability to do care for minors without parent consent is really not available at this time. So that's where we have to be sort of unique and tailored to each individual's circumstance to really work with them to try to get them vaccinated if they actually are eligible.
So next question is, are there any updates to the process to acquire TPOXX for institutions? The current process is complex. I'm sure he'd be right to answer that.
Yeah, I can speak to that, and we understand it is complex. We're still kind of working with the state to get more updates, but right now in the current format, the Houston Health Department has pre-positioned TPOCs here as a method to distribute to your location, but not to dispense. And as we get more information and we're having these forums, we will certainly make sure you all get any additional updates as they become available.
If a patient has had monkeypox infection, how long after, if ever, is monkeypox vaccine okay to be provided?
Okay, so I'll take that one too. We've had a lot of conversation. We've had a lot of conversations because I think what we've talked about too is we're excited that people are asking that question, because really, if they listen to our COVID information, it was you could have had COVID and then you can get vaccinated like after you come off of quarantine. So these are people hearing information about their health, and they're wanting to take, a control of their health decisions. Currently, though, from the CDC with regards to monkeypox, if you've had an infection, then your own natural immunity should be giving you enough protection that you don't need to be vaccinated. And that's the information that we have at this time that's come from CDC.
So how is HHG defining broken skin?
I'm not sure if Julie, you mean if the skin lesions have, I might need a little bit more from what she's asking when she says broken skin.
So, Julie, are you able to clarify? Do you want to?
Yes, thank you. We have had just a question generally about broken skin. Is it, how significant or fresh does like an open area of skin need to be? Let's just say a young person had a large scrape on their leg, but it was fully scabbed. Is that still considered broken, or do we really want there to be like fresh bleeding, or in the sense of eczema? Sometimes I think it's a little easier to appreciate open. We know that we may have nurses taking phone calls about this, and if someone just even has a hangnail on their hand, but then was dealing with linens, but did have like a hangnail, is that then considered open skin? So trying to understand how we're going to make this practical on the front line. Thank you.
I would open that to other individuals, because again, the broken skin is really the ability for transmission of, infectious material and handling infectious material with really an integrity issue of what you've just basically outlined. If the skin does not have optimal integrity, I would be concerned. And so I think no different than we talk about communicable infections when we talk about healthcare providers and Hep B and other bloodborne pathogens, is thinking about it in that same circumstance. You would really want to kind of understand a little bit more of the language of broken skin, or to what you're defining of skin integrity. If you're speaking on testing someone who has that type of description and you're concerned about monkeypox, we've been told you can scrape a scab and you can sort of unroot, kind of go for that material and send it. Some labs are better equipped to test that type of sample material, but we have heard that you can use that material from a testing perspective. If you're asking about that being what someone's asking with regards to their skin integrity and should they get tested.
Thank you.
And if you do, I think Kendrick's point in his case was well taken. Please send multiple samples. I think that's the other thing we're learning, is just a one-time sample sometimes does lend some concern, especially when people do have like eczema and other diagnoses, and you're swabbing and you're looking for like a bacterial infection. So if you're thinking in that along those lines, the more samples you can send, the better.
Yeah. From a lab perspective, we agree that it's always nice to have a second sample to go to if the first one's inconclusive. So that is a very good point. So what support are providers able to offer to patients during the self-isolation period? Sean, you might need to add some more detail to that if you don't mind.
Sure. Thanks, Kendrick, for that case reporting you did. I was curious when you talked about the mental health effects of the prolonged self-isolation. So one, I'm wondering, is it becoming common practice for the providers to follow up with those patients during that period? And if they have access to any kind of support, what that support might look like. Just curious, what are providers able to do?
Great. And before we get to that answer, I just want to say, we're at 1:02, so we're running a little bit over, and I just want to thank everybody. I know time is valuable, so we have to jump off. But I just want to let everybody know before you start getting off that this event belongs to you. So if there is anything you want to see covered in a future forum, or even better, if you want to present something at a future forum, please let us know. We'd love to have you back. And we hope to see all of you back in 2 weeks. We'll have a special guest, Dr. Ann Kimball, who is a member of the CDC clinical consultation team. So thank you, all you for coming, and we appreciate your partnership and support. And so the slogan goes, "We are really better together." Okay. So sorry about that, John. And if anybody wants to chime in on John's question, please do.
And I don't know if Kendrick's still on either.
Excellent. But I guess the answer would probably be
Yes.
to loop in Gilmot if you have any of those questions, and she'll be happy to get you to services, because that's what we do. And that's what we've been telling everybody, is that we want to not just treat the patient, but take care of the whole person, right?
Yes, correct. And of course, we're starting to think about beyond monkeypox as well. So after you did recover, what should you be worrying about? Not worried about, what are the best practices or the health promoting practices you should be doing then? So we're working on continuously developing new content, new module, and also getting feedback from the people we do educate to know what is the next thing you want to know, what is the immediate concern that you have next. So of course, we're always receiving feedback from our community members, but we're also welcoming feedback from our health provider partners as well, to let us know what is the gap that you're experiencing as far as education and what you see. So then we could, on the public health side, we can start anticipating those needs and building out modules and templates and different educational or social media themes that can address those concerns.
Awesome. All right. Well, that will be our last question. And feel free to drop something in the chat if you want to see it answered later. And thank you all for attending, and we'll see you in 2 weeks.
Thanks, everybody.
Thank you.
Thank you.